So let's talk about the adrenergic agonist. So first we have the precursor of noradrenaline or norepinephrine, which is tyrosine. And tyrosine will finally be converted to the norepinephrine through a few steps. And the noradrenaline will go into the vesicle and then it will be released into the cleft. So noradrenaline will then act on the alpha and also the beta receptors. And we also have the noradrenaline or norepinephrine transporter. Okay, norepinephrine transporter will transport noradrenaline back into inside the cell. So that's in brief the major locations of the action of noradrenaline and a brief oversimplification of the production of noradrenaline. And we also know that noradrenaline will be broken down into metabolites by the monoamine oxidase. Okay? The monoamine oxidase enzyme will break down noradrenaline into metabolites. So adrenergic agonists, so they are drugs that mimic adrenergic stimulation or stimulation of the adrenal medulla. So in short, they are compounds that mimic the effects of adrenaline and noradrenaline. So drugs that can mimic, if they have an effect that is similar to adrenaline and noradrenaline, then they are called adrenergic agonists. And these drugs are also known as adrenomimetics or sympathomimetics. Okay, adrenergic agonist, adenomimetics, and sympathomimetics. So actions of the sympathetic nervous system are mediated through the alpha and beta receptors. So alpha and beta receptors. Okay, so these are the main ones, alpha and beta. So alpha 1 are mostly, so you will find in most vascular smooth muscle, okay, the smooth muscle of your vessels. So you have the smooth muscles, and this is the lumen. Okay, you have the tunica, intima, media, adventitia. So and then you have this muscle. So they are you will find alpha 1 receptors on most vascular smooth muscles, and agonist action on the alpha 1 receptor will cause contraction. So you'll have contraction, and this becomes narrow. Okay. So beta 1 is mainly in the heart. Okay, beta 1 is mainly in the heart, and agonist action on the beta 1 receptors will cause the heart rate to increase. Beta 2 mainly in the respiratory and urinary smooth muscle. Okay, when an agonist acts on the beta 2 receptor in the respiratory and uterine muscles, smooth muscles, it will cause relaxation. Okay, so this will relax, and this will relax. Okay, with the respiratory tract, the bronchioles, the bronchus, and also the uterus, the smooth muscles there will relax when acted upon by the beta 2 agonist. So beta 2 agonist, the adrenergic agonist in general, so can be divided into two. They are direct acting and indirect acting. So the direct acting ones bind to receptors, so they are specific, whereas the indirect acting, they do not bind specific receptors, but they release the stored norepinephrine or noradrenaline. So indirect acting ones do not bind the specific receptors, but cause the release of stored norepinephrine. So they are non-specific. So most probably these are like straightforward stuff. And then catecholamines. So it refers to the structure of this group of compounds. Okay, so it consists of a catechol group, so which is a combination of the benzene ring, and two hydroxyl groups. Okay, benzene ring and two hydroxyl groups. So this is called a catechol group. And then we have an amine group. Okay, amine, NH2 amine. So catechol and the amine group. And so this catecholamines, okay, they are metabolized by the catechol O-methyltransferase enzyme and also the monoamine oxidase enzyme. So this catechol O-methyltransferase and monoamine oxidase, they will metabolize the catecholamines. So direct acting agonist, okay, let's talk a bit about that. So only epinephrine and norepinephrine or adrenaline and noradrenaline activate both alpha and beta receptors. So the other direct acting drugs act on either the alpha or beta receptors. So drugs other than the epinephrine and norepinephrine, they either act on the alpha or beta, okay? Whereas the epinephrine and norepinephrine, they activate both the alpha and the beta receptors. So epinephrine has about equal effects at the alpha and beta receptors. And so they have almost equal effects at the alpha and beta receptors. And with regards to the beta and beta 2, the epinephrine, this drug has almost equal effects at both beta 1 and beta 2 receptors. So what do we use the epinephrine for? So you can use it to treat allergic reaction and shock. And you can also control localized bleeding using epinephrine. And also it's used to extend the area covered by local anesthesia. Okay, so for example, if someone has a fall or something and he needs to be given a local anesthetic for his laceration wound, so there is a tear there, so you need to make a stitch. Okay, you need to stitch him up, so you give a local anesthetic. And in order for the local anesthetic to have an extended coverage, okay, so that you have less pain and less chances to get pain, then we give epinephrine inside together with the local anesthetic. So this is a picture of an EpiPen. Okay, it's an epinephrine 0.3 milligram injector. So which are used by patients who are allergic or they are prone to severe allergic reactions. So this is lidocaine, hydrochloride 2%, and epinephrine. Okay. So lidocaine, hydrochloride 2%, and combined with epinephrine. So this is used for infiltration and nerve block. Okay. Nerve block means you want to give the patients so that they don't feel anything in the areas of certain nerves. Okay, so that they don't feel pain. So this is an example of of where we have the lidocaine, say, which is a local anesthetic, which is combined with epinephrine to extend the area of local anesthesia. Next, we have norepinephrine. Okay, so just now we talked about epinephrine. So next, we are going to talk about norepinephrine. So norepinephrine has a lower affinity for beta 2 receptors. Okay, so as we know that And as I have mentioned a few minutes ago, that norepinephrine activates both alpha and beta receptors, but it activates beta 1 more than the beta 2 receptors, as it has less affinity for beta 2 receptors. So due to that, it's not as useful, okay? It's not that useful in the treatment of bronchospasm, okay, as smooth muscle of the bronchioles are relaxed, okay? So it's not useful in the treatment of bronchospasm, okay? For example, in asthma or allergies, severe allergies, where you get bronchospasm, because smooth muscle of the bronchioles are relaxed by activation of beta 2, okay, beta 2 receptors. That's why it's not that useful, because norepinephrine activates more of the beta 1, which we know is mainly in the heart. Okay, whereas beta 2, as we have shown in the previous picture, in the picture like a few slides ago, we mentioned that beta 2 is in the respiratory tract and the uterus. Okay, so if you have the something that acts more in the beta 1, so it's not going to be that useful for conditions affecting the respiratory tract and the uterus, such as in asthma. Okay, so norepinephrine is not that useful in conditions affecting the respiratory tract and the uterus. So we have phenylephrine, for example, of an alpha-1 agonist. So this drug is used as a nasal decongestant. So when you apply this drug locally to the nasal passages, it will cause vasoconstriction. Okay, so it causes constriction of the vessels, and this will reduce blood flow locally and also cause reduced in secretions. So you have less nasal secretions. Okay, so that's why it's useful to be used as a nasal decongestant. Next is clonidine, which is an alpha-2 agonist. So it reduces blood pressure through a central action. So it activates alpha-2 receptors in the CNS to reduce sympathetic stimulation to the heart. Okay, activates alpha-2 receptors in the CNS to reduce the sympathetic stimulation to the heart. And the drug activates the presynaptic alpha-2 receptors on the peripheral nerve endings, which will cause inhibition of the release of norepinephrine or noradrenaline. Okay, it activates the presynaptic alpha-2 receptors. So clonidine causes, okay, clonidine acts here, alpha-2, okay, and finally it will reduce firing of sympathetic nerves. Okay, reduce firing of sympathetic nerves, okay, causes venodilatation of the veins, causing reduced venous return, and also cause vasodilatation of the arteries, which will lead to reduction in total peripheral resistance. Okay, so also act on the sinoatrial node in the heart, causing a reduction in the heart rate, reduction in the stroke volume. So when you reduce the venous return, of course, you will have a reduced stroke volume. Okay, and which will all, if you reduce all this or one of it, you will cause a reduction in the blood pressure. Okay, so that's how clonidine is useful in reducing blood pressure. So it's an antihypertensive. So see you in the next video.